Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen, and as always, I thank you for listening. Today I'm going to cover drugs 131 through 135. And our first medication is Enoxaparin. Brand name of this medication is Lovenox. This is what's called a low molecular weight heparin, abbreviated LMWH. And this medication is an anticoagulant, and it's going to primarily target factor 10A. So again, these are clotting factors, which as expected, if we're using an anticoagulant, we're going to thin the blood, and we're going to prevent those clotting factors from working. So again, low molecular weight heparin primarily targets factor 10A, much more so than thrombin or factor 2A. Okay, so that's kind of on a gradient there, but it tends to block the action of factor 10A a little bit more so than 2A. Ultimately, the blockade of this leads to its anticoagulant effect, thins the blood, and it's going to help treat STEMI, DVT. We can use it for post-op anticoagulation to prevent clotting in patients that aren't ambulatory. Maybe they have cancer, for example. Basically, disease states or situations where they're more at risk for throwing a clot or creating a clot in the body there. This medication is injection only. The higher the dose that we're using, the more and more likely we're probably going to be using that for treatment of DVT, PE, for example, compared to DVT, PE prophylaxis or prevention, which then we can usually get by with a lower dose there. Kind of warnings, precautions, obviously bleed risk. It's going to thin the blood. Naturally, this is a higher risk medication, and ISMP, Institute of Safe Medicine Practices, it is on their list of high alert medications. So primary side effects, bleed, obviously, anemia associated with that, hemorrhage, when patients fall. That's particularly problematic in our elderly patient population that I work with a lot. So sometimes we've got to weigh that risk versus benefit of anticoagulating them if they have a history of frequently falling, for example. And if they hit their head, that could certainly cause some issues with hematoma and bleeding and things of that nature. So something we've always got to kind of weigh that risk versus benefit of, particularly in older, more frail patients. Another thing to consider with the adverse effect profile is thrombocytopenia. More specifically, heparin-induced thrombocytopenia. So this is that ultimately what can end up happening is a significant drop in platelets, and complications associated with this kind of immune type reaction are limb ischemia. It can cause thrombosis, can cause organ infarction. So there are lots of things that can result on account of heparin-induced thrombocytopenia. Typically going to be reversible once we stop the drug, discontinue the drug. That situation will resolve itself, but depending upon the clinical situation, you may need to find another anticoagulant for this patient that's not going to cause heparin-induced thrombocytopenia. With that subcutaneous injection, be sure that we're paying attention to rotating sites. Usually we're not going to use this for terribly long, but if you do have a patient that's on it longer term, that's definitely going to be something to watch for and pay attention to. Reduce other agents that can increase bleed risk, and I'll talk about that a little bit in drug interactions. And then monitoring. We're going to look out for those signs and symptoms of bleeding. We're going to obviously monitor platelets. We're going to obviously look out for dropping hemoglobin indicative of anemia. Wrapping this medication up with drug interactions. NSAIDs, we really want to do everything we can to avoid them. They can increase the risk for that GI insult, GI bleed. Certainly other anticoagulants, other antiplatelet medications, your clopidogrels, aspirins, things of that nature. They can increase the risk for bleed, certainly. Rare potential drug interaction is heparin-based products like enoxaparin do have a small potential to raise potassium levels. So if you've got a patient on a spironolactone, on an ACE inhibitor, so on and so forth, that can kind of have an additive effect there. Other meds that may increase the risk of bleed other than NSAIDs, antiplatelets, anticoagulants. There is some evidence to say that SSRIs can inhibit bleeding a little bit, inhibit coagulation and increase the risk of bleed. So, again, a little bit more theoretical, but there is some evidence to show that might be a risk. Generally, if I've got a patient on sertraline 25 milligrams and they're taking enoxaparin, it's generally not something I worry about too much. But the more and more serotonergic agent we have the patient on, or the higher the dose, we may get a little bit more worried about that. But again, bottom line, we're going to be paying attention to bleed risk, platelets, and all that stuff anyway when we're using anticoagulant like enoxaparin. Moving on, we've got a stimulant medication, and that is methylphenidate. The brand name of this medication is Ritalin or Concerta. There's a bunch of different dosage formulations with this medication. Again, classified as a CNS stimulant, central nervous system stimulant. Ultimately acts on the brain to block reuptake of norepinephrine and dopamine in presynaptic neurons. Indication is ADHD. That's the primary use I see it used for. Occasionally I have seen it used for narcolepsy. Rarely I have seen it used off-label to kind of stimulate energy in rehab for older patients or patients that have just undergone, let's say, a knee surgery or something like that. Not something I generally recommend because we have plenty of side effects and issues with that. But I'd be lying if I said I hadn't seen that before. So there is the risk for abuse, misuse, addiction. So that is definitely problematic. It is a Schedule II controlled substance. So that's the highest classification that still has medical purposes. So very, very important to pay attention to this, that people don't get addicted to it. And we watch that closely, particularly in patients that may have a risk of addiction and dependence in the past. Now, the adverse effect profile, this is something I think is really, really important. When we increase the amount of norepinephrine in the brain and in the body in general, that has kind of a stimulatory effect. So insomnia is a very common adverse effect. Elevations in blood pressure. It can cause tachycardia and palpitations. It can also cause weight loss, which, if we're using this in a pediatric patient who's still growing, we're treating their ADHD with this medication, we've got to pay attention to potential for, weight loss, poor appetite, and make sure that patients are on an adequate growth profile there. So something that we're definitely going to monitor. In association with that insomnia, you can also have some anxiety and irritability. Remember, this medication can potentially amp patients up a little bit. Other things to look out for, any type of serious cardiovascular risk or adverse effects there. It can cause what are called tics, so that's something to look out for as well. And it can worsen some psychiatric conditions, can kind of induce or worsen mania in patients with bipolar disorder, can worsen psychosis potentially as well. Wrapping up with drug interactions on this medication, MAOIs can increase the risk for hypertension, causing that blood pressure to go up in combination with a medication like methylphenidate, so that's something to generally avoid. Additive serotonergic activity has been reported with methylphenidate in combination with SSRIs and other antidepressants that have serotonergic activity. Again, not something I'm probably crazy worried about, but certainly has been reported in the literature. Interestingly, alcohol may increase absorption of some formulations. So, typically alcohol is probably not going to be an issue in some of our younger patients, 8, 10, 12 years old, or at least hopefully not. but in older patients, that may alter the absorption of some of the formulations. So if you see a patient that's having some fluctuations or some issues, asking and inquiring about that alcohol intake may be helpful in recognizing some changes in, pharmacokinetics and concentrations that may happen because of that. And then the last one I'll mention is bupropion. Methylphenidate does have some potential evidence to show some seizure lowering or seizure threshold lowering activity. Bupropion certainly does as well. So, the additive combination could increase the risk for seizures potentially. Hey, don't forget to go check out reallifepharmacology.com. I've got that free top 200 study guide, 31-page PDF, absolutely free. Simply an email will get you access to that. Definitely a no-brainer to go take advantage of that. All right, moving on, we've got medication 133. This is Rosuvastatin, brand name is Crestor. This is a statin-type medication that lowers cholesterol. Ultimately, it does that by inhibiting HMG-CoA Reductase, and this is the rate-limiting step in the body's production process of cholesterol. Ultimately, what we're trying to do with a statin medication is lower LDL, which ultimately helps reduce cardiovascular risks and bring down that cholesterol. Now, some of the warnings, risks associated with this medication, rhabdomyolysis. It's a very, very severe but rare reaction where basically we get some muscle breakdown that can lead to acute renal failure and other problems as well. So the telltale sign, symptom that may be indicative of this is elevations in CPK, combined potentially obviously with some muscle soreness and that type of thing. But patients can have muscle soreness, which is probably more common, or it is more common than the severe rhabdomyolysis type situation. So muscle pain, muscle soreness certainly has been reported with statins there. So pay attention to that. Other potential adverse effects, you can have some GI upset and that type of thing. Again, not incredibly common. It's more so myopathy. That's the one that you're probably most likely to be tested on, as well as that kind of rare but severe case of rhabdomyolysis, where we get the muscle breakdown, leading to complications with the kidney and other aspects there. Some considerations, things to pay attention to. So adherence is usually terrible. To be brutally honest, it's usually not good as far as cholesterol-lowering medications. So it's something to inquire about if you're dispensing in a pharmacy, for example. It's good to be able to see the dispensing records and say, hey, is this patient taking their statin as recommended, which many times patients struggle with that. Drug interactions profile. There are some azole antifungals like itraconazole that may increase the concentration of rosuvastatin. I will say the CYP3A4 interactions, much, much more prominent issues with simvastatin and maybe even atorvastatin than there is with rosuvastatin. So I would say on that scale of CYP interactions, rosuvastatin definitely isn't near as bad as atorvastatin or simvastatin. Other medications to think about, daptomycin, that can increase the risk for that muscle pain, muscle soreness, as well as rhabdomyolysis. Fibrates as well, so fenofibrate, gemfibrozole, there's a potential increased risk for myopathy and rhabdomyolysis as well. All right, moving on, we got 134. This medication is Denosumab. Brand name, or the primary brand name I see, is Prolia. This is a monoclonal antibody. It causes receptor activation of nuclear factor kappa B ligand, rank L. It inhibits that, and then that binding to rank L ultimately inhibits formation, function, and survival of osteoclasts. If you remember osteoclasts, they actually break down bone. So if you inhibit the action of osteoclasts with this medication, that ultimately helps reduce bone resorption and ultimately increases bone mass and strength. So, as you can imagine, the primary indication of this medication is osteoporosis and osteopenia, in kind of those brittle bones. And it can also be used for hypercalcemia of malignancy. Those are the two big ones that I've seen it used for, with osteoporosis being obviously a much more common condition, at least in the patient population that I work with. Other adverse effects to think about can be, some issues with the injection. Obviously, probably the biggest one from a monitoring standpoint is calcium. So it can cause some lower blood calcium levels. So that's definitely something that you're probably going to want to monitor periodically. Can rarely cause some fluctuations in cholesterol, maybe some GI upset, that type of thing. And then I have seen some kind of muscle soreness, arthralgia type pains as well associated with this medication. So again, one more thing to kind of look out there for. One patient population to pay attention to is patients with advanced kidney disease. They may be a little bit more at risk for kind of unique calcium fluctuations and particularly hypocalcemia in combination with this medication. They may be a little bit more at risk for that. So some considerations, things to pay attention to: sub-Q injections, so rotating those injection sites. Rare associations with this medication. Osteonecrosis is reported with this medication, just like the bisphosphonate medications, like Resedronate, for example, or Alendronate. So that is something to pay attention to. Patients may be more at risk, if they're having an oral surgery recently, for example. Most of these patients are probably going to want to supplement with calcium and vitamin D. Again, we can assess some levels and check that too to make sure that that's an appropriate recommendation. But for most patients, that is certainly going to be okay to recommend there. Drug-drug interaction standpoint, I wanted to mention the low calcium risk. So we do have some meds. If we're using a loop diuretic, that can potentially lower calcium levels. Calcimimetics are probably a much more significant or severe interaction than loop diuretics, but a medication like Cinacalcet can potentially lower calcium levels. And then last, there is some association in use with immunosuppressive agents that it might have an additive type effect. So medications like corticosteroids, maybe some of the oncology agents like methotrexate, any medications that have immunosuppressive action, Denosumab could potentially add to that. All right, I got one last drug, but we'll take a quick break from our sponsor here. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or Naplex, go check out meded101.com/store. We've got a growing list of resources there, tons of testimonials. Thousands of pharmacists and other healthcare professionals have used our content to prepare for board exams, so you can feel assured there as well. Again, all those links, meded101.com/store. If you're a nurse, pharmacy technician, we've got books available as well at meded101.com/store. So go check that out. Support the sponsor, Meded101. All right, finishing up, we've got Dabigatran. Brand name is Pradaxa. When this medication initially came out, I did see quite a bit of use with it. I would say now it's probably more so been taken over by Apixaban, Rivaroxaban. So if you know that medication's kind of in that class, this is an anticoagulant medication. It is oral. It competitively inhibits thrombin, which ultimately prevents thrombus formation. So again, trying to prevent blood clots and thrombus from forming. It is twice daily dosing. It is an oral medication. Pay attention to renal function with this medication. We do need to reduce the dose if a patient's renal function declines too far, so that's important. And obviously, being an anticoagulant type medication, can be used for DVT, PE prevention and treatment. Also, atrial fibrillation, we're reducing the risk of stroke in patients with that diagnosis as well. A little warning, precaution, don't prematurely discontinue, as this can increase the risk for thrombotic events. From an adverse effect monitoring standpoint, bleeding. That's going to be the major risk here. Risk of GI hemorrhage, CNS hemorrhage, GI upset also has been reported with this medication. So ultimately, we're going to have our patients monitor for the risk of bleeding. Obviously, report that back to us as healthcare professionals. Pay attention to any type of surgical procedures coming up and what the process should be. Does the patient need to hold this medication before or after the surgery? What needs to happen there? Always a good discussion point with who's ever doing the surgery and the type of surgery involved there. Avoid aspirin, NSAIDs if at all possible. Again, going to significantly increase the risk for bleeding there. I think one of the major reasons is we've got an increased, one of the major reasons that this has fallen out of favor a little bit compared to some of the other agents, maybe some of the efficacy data. But as patients get older, this medication has shown to have a few more risks. So patients over the age of 75, it's recommended to use this medication with extreme caution or consider other alternatives. Okay, and that's ultimately because the bleeding risk from this medication increases significantly as patients age there. Finishing up with drug interactions, we do have a few with this medication. Certainly I alluded to NSAIDs, other antiplatelet medications, anticoagulants. Really want to try to avoid combining those if at all possible. Other medications, we do have some cardiac type medications. Verapamil can increase Dabigatran. Amiodarone has been associated with increasing concentrations. Clarithromycin can increase concentration. That's antibiotic for infection. And then we do have some enzyme inducers. A classic example there being carbamazepine that can lower Dabigatran exposure and ultimately reduce efficacy. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, share us with friends, colleagues, pharmacy students, nursing students, medical students, anyone who could benefit from pharmacology education. I greatly appreciate that. Leave us a rating review on iTunes or wherever you're listening. Greatly appreciate that. If you got comments, suggestions, don't hesitate to reach out to me at mededucation101@gmail.com. And thank you so much all for listening, and I hope you have a great rest of your day.